Hi, everyone, and welcome to today's Student-Led Journal Club seminar series. I ask that you please mute and turn off your cameras for the presentation, and then save your questions till the end. I will help moderate those and we can get any of them answered. So now to introduce our speaker, student Dr. Joanna Tabor is a third-year medical student at SUNY Downstate in Brooklyn. She has a Bachelor's of Science in Neuroscience from NYU. Her research interests include neuro-oncology and neurotrauma, and today she will be presenting through the Neurosurgery Education and Research Virtual Interest Group, which is also called NERV, in collaboration with the MKRC. Please feel free to go visit NERV's Canvas page on the MKRC Canvas page that we host if you're at KCU for more information if you are interested in neuro or neuroscience, neurosurgery related topics. And with that, I'll let you take it away, student Dr. Tabor.
Okay, great, thank you. So my presentation is on second window ICG for brain metastases. So this is a topic in neuro-oncology. So before we go a bit into the paper, I'm just going to give some background information on brain metastases and why this work is relevant for brain metastases. Okay, so brain metastases are actually the most common malignancy of the central nervous system. So about 20% of all patients who have cancer will at some point develop brain metastases in their clinical course. And often it can be the initial presenting symptoms. So patients can have no symptoms of their high-grade cancer until symptoms of a brain metastases occur, such as focal neurological deficits, or symptoms of increased ICP or other things. The most common cause of brain metastases is lung cancer by far, followed by breast cancer and melanoma. Together, these three make up about 67 to 80% of all brain metastases, and some more common ones include renal cell carcinoma, and also there's colorectal carcinoma, which has been increasing in prevalence recently. And there have been some studies showing hematologic cancers that can actually present with brain metastases. So the current treatment for brain metastases is really multimodal. We use many things, including surgery, radiotherapy, chemotherapy, immunotherapy, and targeted therapies. So there are a lot of therapies aimed at trying to treat brain metastases. And even with all these therapies, there still is a very high rate of recurrence. So traditionally, when you have surgery paired with stereotactic radiosurgery or radiation therapy, there's still a recurrence of about 10% in these treated tumors. And prognosis remains pretty poor. So when you have adjuvant radiotherapy paired with surgical resection, it improves the overall survival from 5 months to 12 months, but it's still a pretty poor prognosis. So there's a lot of research going into the topic of brain metastases and trying to improve their prognosis. So one of the criteria for treating brain metastases with surgery is a KPS score above 70. KPS quantifies functional impairment. So a higher KPS score actually indicates better functioning. So the patients that actually get surgery for brain metastases are not that impaired. They're usually able to do most things on their own. They just need some assistance. And then they usually have to have a solitary lesion that's easily accessible to surgery. There are some cases in which you can have multiple lesions that are amenable to surgery, but it's really a case-by-case basis. So you can see that the treatment of brain metastases is pretty complicated, and it's a very common malignancy. So given this high incidence and the proclivity for recurrence and their poor prognosis, there's still a lot of work to be done, which brings us to the topic of this study. So the title of this study is Second Window ICG Predicts Gross Total Resection and Progression-Free Survival During Brain Metastasis Surgery. It's actually based on a prospective study, a pilot study done by the same group in 2017. And they are the pioneering research group to actually developed this second window ICG protocol. So this is their follow-up study to see the clinical outcomes of this ICG. So now I'm just going to go a bit into what second window ICG exactly is and kind of the rationale and precursors that led to the use of it in this study. So for brain metastasis surgery and a lot of neurologic malignancies, actually, you really want to have gross total resection, meaning total resection of the tumor, to improve the overall survival time. And you don't want to leave any residual tumor behind because you have increased progression of the tumors and increased recurrence. So strategies to really ensure that you have accurate gross total resection and are removing the entire tumor are important for improving brain metastasis surgery outcomes. So there are some current techniques currently used. They include intraoperative neuronavigation, cortical mapping, and focused ultrasonography. But not all brain tumors have distinct borders. So you can't really tell where the border of the tumor is compared to healthy brain tissue all times. So when you resect them, you can have some leftover tumor tissue. So this is where fluorescence guided surgery comes into play. So you use a fluorescent dye that lights up the entire malignant tumor, including the cells you wouldn't be able to see normally, so you can ensure that you get the whole entire thing out. So 5-ALA is a type of fluorescent dye that is being used for high-grade gliomas with a lot of success. And they tried using 5-ALA for brain metastases, but it wasn't as successful as it is for high-grade gliomas. So it only enhanced about 2/3 of the brain metastases, and 1/3 of them didn't light up at all, so it's not reliable enough to use. Which brings us to the other type of fluorescent dye that you could use, which is the second window ICG. So ICG stands for indocyanine green. It's a fluorescent contrast that's FDA approved for other things, including surgeries like sentinel lymph node biopsy. So it allows the sentinel lymph nodes to be visualized with fluorescence, for example, in breast cancer surgery. And it's also used for various perfusion studies in the body. So it's been used for quite a while, actually, but it hasn't been used in the brain until this research group pioneered it in 2017. So it's actually very, very successful in lighting up brain metastases. So it lights up all of them, and it's very reliable. And the term second window refers to the fact that it's a delayed infusion. So you infuse either a high dose of indocyanine green, ICG, which is 5 milligrams per kilogram, or a low dose, which is 2.5 milligrams per kilogram. And you infuse that IV over 1 hour, and that's 24 hours before the surgery itself. And you want to infuse it 24 hours before so you have maximum accumulation in the neoplastic tissues because it's passively absorbed. And one interesting thing is that ICG actually doesn't cross the blood-brain barrier. And since it's injected IV, that's a limitation because how will you get it from the vasculature to the brain tissue itself? But actually with brain metastases and other tumors, you actually have a breakdown of the blood-brain barrier, so the ICG is able to get in. And then since it's a near infrared, you can't see it with your vision alone, so you have to use an iridium exoscope with an 805 nanometer excitation source, and then an emission filter to pick it up. So you have an example here of what an exoscope might look like. So you would actually have to look at this screen to see the tumor itself light up. So some more methods about the study itself. The study population was 54 adults undergoing a craniotomy for an intraparenchymal metastatic brain tumor. The original pilot study had 13 patients, and they weren't included in this, I believe. 7 patients were excluded, 5 of them because they underwent endoscopic surgery and not craniotomy, and 2 of them because of imaging technical difficulties in the OR. 26 patients had a high dose of 5 milligram per kilogram, as opposed to 21 who had a low dose. And the high dose patients were the ones who received their surgery before April of 2018, and the low dose were after April of 2018. And the reason the researchers did that was because they wanted to see if a lower dose of the ICG would still have the same effects as the higher dose. So they only included tumors that were less than 10 millimeters deep, and that's because there's some difficulty with getting the near-infrared photons to penetrate into tissues that deeply. And the tumors that are deeper in the cortex, you can't really visualize well. And then to determine and quantify the fluorescence, they use a signal to background ratio calculation. So they assess the fluorescence of the background and then compare it to the fluorescence of the tumor itself, which is the signal, and subtract that to get a value that quantifies the degree of the fluorescence. And they also did 2 post-op MRIs. These were contrast with gadolinium contrast. The first one was on day 1 post-op, and the purpose of this one was to check if there was any residual tumor left after resection. And then a post-op MRI on day 30, again with contrast, to see if there's any recurrence or progression of the tumor. So now we're going to go into the results of the study and some pretty images that they have. So this first panel shows us an example of a successful and an unsuccessful ICG. So in the top tier, if you can see my arrow, is a successful ICG infusion. So in panel A, you have an MRI with contrast preoperatively, and you can see this tumor right here at the great white junction in the right hemisphere. See, it's well circumscribed. And then in panels B and C, we have what the tumor would look like with the ICG infusion and the near infrared imaging intraoperatively. So this is with the open tumor in the OR. They're taking a picture with that exoscope. And here the dura is actually intact. So you can see where the brain tumor is with the use of ICG through the dura, which is useful for surgeons because then you can make a more precise incision. So you can get exactly to where the tumor is. And this is different from other fluorophores like 5-ALA because you can't see those through the dura. They have to be visualized directly. So this is an interesting quality of ICG. And then in D and E, we again have the ICG near infrared imaging, but now the dura is open. So we have a durotomy. You can see directly into the cortex. And again, we're seeing this tumor light up beautifully with the ICG. You can see the yellow and the red indicates higher signal. And towards the outside, you have the purple, which is a little bit lower signal compared to just the black and white version of the near infrared view. So these are actually the same thing. They're both ICG near infrared, except this one has a color overlay and this one has a black and white overlay. And then here they have an example of how they calculated the signal to background ratio. So the tumor is a signal, and this is the background, and they subtract these 2 values to get 1. And then in the bottom tier is what the researchers characterize as a poor ICG. So this one was actually low dose. The upper tier was high dose. And in the low dose, again, pre-op MRI, you can see the tumor right here in the right hemisphere. You can also see some significant edema surrounding it. And then in the dura view, you can see that you can't really localize the tumor itself. The entire dura is kind of lighting up with the near infrared imaging. Same goes for the white and black view. And then once you do a durotomy and you open the dura, you can now clearly localize the lesion right here. So a well circumscribed lesion that's really enhancing beautifully with the ICG. So they quantified this as, or rather qualified it as unsuccessful because you couldn't see the tumor itself through the dura. And then here I have a link to a video showing the surgery itself. Hopefully it loads soon. And the sound is off because it's just background music. So here you see the tumor through the dura. Once the dura is opened, and again, it's visualizing the tumor. So now they're excising the tumor with the ICG fluorescence. And they're actually removing this tumor en bloc, meaning that it's taken out in one piece, as opposed to piecemeal. There are studies showing that if you take out the tumor piecemeal, there's actually more recurrence than if you take it out en bloc like this. So it's the preferred method. And then at the end, we saw some residual fluorescence. So then they underwent radiosurgery and they had no evidence of residual tumor on post-op MRI. Okay. So on to some more results from the study. This chart is actually just really quantifying that first image that I showed you. So the fraction of accurate tumor localization through the dura using high dose or low dose ICG. So here you have high dose, and you can see that it's much better at localizing the dura, the tumor through the dura, as opposed to low dose. And this is a significant difference. Meanwhile, when you do the same thing but visualizing the tumor through the cortex, there's no significant difference between a high dose and a low dose. Nonetheless, ICG, both high dose and low dose, is still quite successful in identifying tumors through the dura. So total, there's 76.9% of tumors that were identified through the dura correctly. Still pretty successful. And then when it comes to identifying the tumors through the cortex, it's 95% successful, both high and low dose. So on this slide, we have on the x-axis signal to background ratio, indicating the how high the fluorescence is. And then in the y-axis, we have different types of cancer pathologies of the brain metastases themselves. So lung, cancer, colon, and others are all pretty much the same when it comes to the degree of fluorescence, but melanoma is significantly less when it comes to signal to background ratio, so it doesn't fluoresce as much as the other tumors. For some reason, it acts differently, and the researchers aren't really sure why. And then when it comes to pathologies with different doses of ICG, so high versus low, all of them acted the same when it came to high versus low, except for lung cancer. So in lung cancer, there was a higher signal to background ratio when infusing a higher dose and a lower signal to background ratio when infusing a lower dose. And they found no correlations between signal to background ratio with patient sex or prior surgery, prior radiation, tumor location. And interestingly, only the tumors that were less than 10 millimeters deep had a good signal to background ratio. So deeper tumors were harder to visualize. So this brings us to the more impactful results of this study. So on this slide, we have the neoplastic margin detection using NIR fluorescence. Essentially in this table, what we have is the surgeons took a tumor margin and determined whether it was positive or not for a tumor based on the surgeon's impression using either near infrared viewing for ICG or under regular OR white light. So they took a piece of tumor margin and determined if it was positive, yes or no, based on what they saw on the near infrared view or the white light view. So when it comes to white light, there is a sensitivity of 36.8% compared to 100% sensitivity for near infrared view. So the ICG was able to pick up 100% of the tumor margins that were actually positive, as opposed to about 37% in the white light view. But then conversely, the specificity is high for white light, but it's very low for the near infrared view. So it's only 19%, which is a pretty low specificity, meaning there are a lot of false positives The surgeon said that there was tumor in the margin, but there actually wasn't. And that's something you want to avoid in brain tumor surgery or any brain surgery, because the brain is very delicate and there are a lot of eloquent areas, so you want to preserve what you can. So in the end, the accuracy for the near infrared view was actually lower than the white light view because of this low specificity. So to address that, the researchers did an ROC curve analysis to try to find the threshold of signal to background ratio that would give us the best accuracy. And they found that a signal to background ratio greater than 3 gives you the best accuracy. And that's compared to the surgeon's impression, which correlates to about a signal to background ratio of 2. So when you apply this threshold of 3, the sensitivity goes down to 84.2%, the specificity goes up to 61.9%, and the accuracy improves. So now it's 72.5% compared to the 67.5% for white light. So with this new threshold, the near infrared view is more accurate at determining positive tumor margins compared to regular OR white light. Given this, there's still some way to go, since we don't have technology that will allow you to know when the signal to background ratio is greater than 3 intraoperatively. So that'll take some work. On the next slide, so here we have a correlation of post-resection near infrared view to post-operative MRI. So essentially, how well does the view using ICG intraoperatively compare to what you see on post-op MRI? So in the first panel, or the top tier, we have an example of what gross total resection would look like, so removal of the entire tumor. Panel A have preoperative MRI with contrast. You can see the tumor here on the right hemisphere again. And post-op MRI, you can see there's no tumor left, there's no residual enhancement, indicating that the entire tumor was taken out and gross total resection was achieved. Panel C is what you would see intraoperatively after removal of the tumor with the regular white light of the OR view. So you can see it's kind of hard to tell if there's anything left over. When you use the near infrared view for the ICG, the black and white overlay, you don't see any residual fluorescence. So nothing is lighting up, indicating that the whole entire tumor was taken out. And with the pseudo color overlay, you're seeing the same thing. There's no fluorescence. And this correlates to the post-op MRI. So you can tell when you're doing the surgery at the end, before closing, that you most likely took out the whole entire tumor. And then for non-gross total resection, so not taking out the whole tumor, pre-op MRI shows a tumor here. Post-op shows this residual enhancement, this little nodular enhancement here with the arrow pointing to it. So not the entire tumor was taken out. Under white light view, it's really hard to tell. There's kind of this black residual stuff, but you can't tell if the tumor is there or not. For near infrared view with black and white overlay, you can clearly see now that there's this fluorescence here around the periphery of the cavity from the resection. And the same thing goes for the pseudo color overlay. You have this purple enhancement here, and it actually correlates to where you see the residual enhancement on post-op MRI, showing you where the tumor is left over. And also, based on all 44 cases that were done, 16 of the 44 showed no residual fluorescence in the operating room. And then when compared to post-op MRI, all 16 of those cases showed complete tumor resection. So there was 100% overlap between what they saw in the OR showing no residual fluorescence and no post-op MRI enhancement. Then when it came to residual fluorescence, was also not highly specific again. So sometimes there are cases where there was residual fluorescence intraoperatively and it looked like there was still tumor left. Then when you did the post-op MRI, there was no enhancement. So again, we had false positives, the low specificity. So some clinical outcomes of the study. In panel E, we have, so these are all Kaplan-Meier curves. In the y-axis, we have progression-free survival time. For the x-axis and the y-axis is survival probability. So on this one, they're comparing positive fluorescence on near-infrared final view compared to negative fluorescence and its association with progression-free survival time. So there is a difference in the curves. When there's a positive fluorescence, meaning there's seems to be leftover tumor intraoperatively, the progression-free survival time is lower. It's about 20% compared to negative fluorescence, so no obvious tumor left over intraoperatively, which has a higher PFS of 38%, I believe. So it's not actually significant, P equals 0.25, but there is some kind of pattern here compared to how post-op MRI correlates with progression-free survival time. You can see with the dashed line, which means no residual enhancement on post-op MRI, and the solid line, which is residual enhancement, they're nearly overlapping. It almost looks like the same line. One of them is 27%. I believe that when there's no residual enhancement on post-op MRI is 27% for PFS, and residual enhancement is 29%. So they're very much similar. So it looks like the near-infrared positive fluorescence versus negative fluorescence is better at predicting the progression-free survival time for these patients than the actual post-op MRI. And then in panel G, they found a significant association between prior surgery on brain metastases and progression-free survival time. So patients who had prior surgery had a much shorter progression-free survival time, and this is a significant association. They didn't find any association between sex or age with progression-free survival time. And then in panel H, they're comparing the different cancer pathologies with their progression-free survival time. So again, melanoma is kind of doing its own thing here. It's the only one that has a significantly different progression-free survival time. It's much longer compared to the other pathologies, including colon, breast, and lung, and others. So actually, when they were doing the analyses for ENF, they excluded melanoma because it acted so differently in terms of progression-free survival and the actual signal to background ratio and enhancement of the fluorophore. So these results are not including melanoma. And interestingly, of the 16 cases that ended up having recurrence at the last contact in the study, post-op MRI showed residual enhancement in 8 of them, and near-infrared showed residual fluorescence in 12 of them. So again, the ICG was better at predicting who would have recurrence compared to the post-op MRI. This wasn't a significant association at all. And then some limitations of the study. So the first one is that there's some possible sampling bias. The samples of the tumor margins weren't taken really at random because you want to avoid eloquent areas and preserve important brain tissue. So you have this effect on sensitivity and specificity, which may be biased due to this non-random sampling. There's also a poor understanding of ICG localization in tumors. Though this technology has been used for a while now, they're still not sure exactly how it works. So there's this belief that ICG is taken up into cells by endocytosis, and researchers believe that it also leaks out of tumor cells into the surrounding matrix, and then may be picked up by surrounding healthy cells through endocytosis. So it's not really clear what exactly is lighting up with the ICG, and this may be part of why the specificity is so low, because it's not purely localized to the tumor itself, but also kind of enters the surrounding matrix and cells. And the last limitation is that there's no randomization in the study. So this is a retrospective study. All of them had the near-infrared view. So the next step would be to have patients who get the ICG versus patients who don't and compare their clinical outcomes to see if there's really a difference. Nonetheless, even with these limitations, it's still a pretty exciting development in neuro-oncology. It's kind of furthering the development of fluorescence-guided surgery, which is already pretty promising in high-grade gliomas. And actually, since this group pioneered second window ICG, it's been studied in other types of brain tumors. So it's been used in things like high-grade gliomas and craniopharyngiomas, pituitary tumors, and others. So it's really starting to be looked into more as a type of fluorophore used in various neuro-oncological surgeries. And it's interesting to see this evolution of fluorescence-guided surgery. So it might be a part of our treatment of brain metastases in the future. And these are my references. And I guess I'll open it up to questions.
Great presentation, thank you. Anybody that has a question, feel free to either unmute and ask or use the raise hand function. And you can also type it in the chat if you can't speak or if your mic's not working.
Well, I was going to defer, but since nobody else is talking, I'll ask a couple. So I was curious from the outset how it actually got localized there, because it binds tightly to plasma proteins. So you were talking about there being no blood-brain or broken down blood-brain barrier as a means for it getting there. So that you partially answered that question. Now, with it being near infrared, I mean, among the advantages is that near infrared penetrates deeper. So short wavelength can't penetrate nearly as deep. So while you were sitting here and talking, several things crossed my mind. And so number one is, why are they visualizing the whole tumor? Why aren't you just going in there with a little needle fiber optic light guide and going in there and right at the area that you need? That's all where I'm going to make the cut. That's the only place where I need to see. So that was one thing I thought that, could potentially increase the depth, because if you're restricted to only 10 millimeters deep, it seems to me that there's a good chunk of brain beyond 10 millimeters deep. But then the other thing that, as I was playing with this in my mind, was if it's getting in there because you're dealing with the fact that the blood-brain barrier is broken down, why can't you resect the tumor to the extent that it still has a capsule around it? And if you got margins that are a little bit more finicky, have a second dye in there, just like they treat psoriasis or something like that, and then hit it with a UV dye and blast the hell out of residual cells that you couldn't potentially resect. So that's me sitting and thinking, not doing anything along these lines.
Okay, I'll try to answer some of those questions. So yeah, it is a plasma-bound protein, and they did say that it washes out quite quickly from tissues, which is why they use the second window, 24 hours, because by passive absorption, the tumor will pick it up more so than the surrounding tissues. That tumors use more or have higher metabolism than surrounding cells. So when you use a signal to background ratio, you're able to see comparatively that the tumor took up more, and you're able to determine this fluorescence. So that's how they did that. And in terms of
can I stop you there for a second on that? So that's the basis for PET scanning, I know, or you're dealing with the fact that the tumor is taking up a lot of glucose because you don't have your Krebs cycle generating ATP. So it's saving the carbon chains. But it doesn't quite make sense to me that it would take up a dye more rapidly if it has to endocytose to do that. So perhaps I didn't quite understand how it was actually getting in the cells.
Yeah, and that's a good question. And again, they're not very clear on how these tumors take up ICG. It is a pretty new use of ICG to be localizing tumors, and it's not clear what the mechanism is. So while they believe is through endocytosis, we don't really know. They just found this association, and they're kind of going with it. It's a new technology.
Thank you.
You actually answered a question I just got in the chat kind of about that. So I got a really good question that says, did you read anything regarding what the ICG binds to in or on tumor cells? And then a follow-up was, does this vary by type or genetic tumor?
I'm sorry, I kind of didn't hear the last bit of the question. Does it vary by type or?
Genetic makeup of the tumor.
Yeah, so I think the only type of tumor they were showing us that there's a difference in was the melanoma metastases. So those seem to be picking up less ICG. They had a lower signal to background ratio. For the other types of brain tumors, I wasn't able to read the literature on it. There's actually been a lot recently. So I don't know how it's targeting those, but they all seem to be taking it up. So it doesn't seem like it's very specific to a type of tumor. Maybe some of them pick it up less, but it seems to target all of them. And then, sorry, what was the previous question? Oh, does it bind to anything? So yeah, it's plasma bound, so it doesn't really have a specific target. It's just picked up through diffusion.
Awesome, thank you. And then I also just got another question and it says, have they tried using this in any other location of tumor? So I'm assuming not brain tumor, but tumor elsewhere.
So yeah, I think it's used, like I said, the sentinel lymph node biopsies. It's used for, I think I saw in passing that it's used for colorectal carcinoma. I didn't read into it that much, but I did see that as well. Yeah.
Thank you. Does anyone else have any other questions? Or again, feel free to unmute, raise your hand, or just type them in the chat. Dr. Staudinger just put a link in the chat.
It's identifying a transporter that works to transport indocyanine green, at least in liver, I believe, at first blush. I thought that might help answer. Perhaps I was thinking that in a brain tumor, there may be some uptake transporter that's upregulated that helps it get in there selectively.
Well, if there aren't any other questions, I just want to say thank you so much again, student Dr. Tabor, for presenting. That was a great presentation. It was really interesting. That video was so cool to actually see it in action. So really appreciated the video.
Thank you for having me.